hear you. Sorry.
Oh,
Go ahead.
can you hear me now?
Yes.
Okay, very good. My apologies. All right, so no, that's not what I wanted to do. All right, how about now? We got content. All right, so hearing no concerns, we'll go ahead and get started. So again, thank you for that introduction and certainly the invitation from the Southeast Society of Critical Care Medicine. And I look forward to hopefully talking to you about something that is near and dear to you, just as it's near and dear to me, and it's actually working towards health equity in critical care. And so really briefly, I have nothing to disclose. Nobody's paying me, no drug companies are paying me, so they don't want to hear from me anyway, but in any event. Briefly, just highlighting what we'll be talking about today, we'll be highlighting ways and terms for clinicians to identify racial disparities that have been commonly described in the critical care literature. We'll describe potential causes of racial disparities in critical care, and then we'll apply principles of health equity to critical care practice. And so how we will achieve that is looking and providing an overview of drivers of health disparities. We'll then spend some time specifically looking at critical care health disparities, looking at it through the lens of COVID, but also looking beyond COVID to understand what disparities are present. And then we'll be closing with a more forward-looking strategy to identify ways that we can promote health equity. And
Dr.
so,
I'm
yes.
sorry to interrupt. We're only able to see half your screen.
Okay,
do you mind
let's see how we can. All right, my apologies. Let's stop share and then start over. How about now?
Still have the screen.
All right, let's see. Still only half the screen?
So with this, I actually see like your entire PowerPoint view. So I see the full slide, but it's smaller. That's odd.
That is odd. Let's try one more time.
Sure.
How about now?
That's perfect. Thank you.
Perfect. My apologies. If you can tell, I'm a Zoom user, so using GoToWebinar is a little bit outside of what I normally do, but we'll continue to press on. And so let's talk a little bit about health equity as it relates to what it is. I think that's always a good place to start. And so health equity essentially means that providing the opportunity for everyone to have a fair shot and just opportunity to be as healthy as possible. The figure on the right illustrates and compares equality versus equity. And so equality essentially means giving everyone the same tools. However, as you can see from the figure from the Robert Wood Johnson Foundation, that different folks have different needs. And so giving the same tools to everyone doesn't necessarily meet the needs of everyone. And so to achieve health equity, that requires us to remove obstacles to health and consequences of those obstacles. And some of those obstacles that are frequently noted to inhibit health equity include poverty, discrimination, and lack of access to good jobs. And that needs to be replaced with fair pay, quality education and housing, safe environments, and quality healthcare to achieve the mission of health equity. So COVID-19 itself, as well known to this group, has exposed longstanding inequities that have systematically undermined health of racial and ethnic minority populations. As illustrated in the disproportionate burden of COVID-19 on historically minoritized communities. And so when we talk about health equity, I think it's important for us also to understand terminology when we talk about health disparities versus health inequities. And so health disparities are essentially differences in health status and mortality rates that often affect socially disadvantaged groups, but don't necessarily themselves imply that there is anything untoward, versus health inequities, which are differences in health status and mortality rates that again affect socially disadvantaged groups. But these differ from disparities in the sense that they are systemic, avoidable, unfair, and unjust. And so, for example, when we talk about breast cancer mortality, comparing Black women versus white women, largely those differences in outcomes are rooted in social and structural inequalities that contribute to health. And so when we talk about health equity, we can't have the discussion without understanding factors and structures that contribute to health inequities. And so that's classically described as systemic or structural racism. And by definition, this is the totality of ways in which societies foster discrimination through inequitable systems that themselves reinforce discriminatory beliefs as well as outcomes. And so, for example, when we talk about systemic racism or structural racism, they increase the risk of adverse health outcomes. And so some examples of systems in which that promote structural inequality include housing markets. When we talk about, for example, redlining, and that's historically been something that's happened in the United States, but also the remnants of redlining and policies are still present today. And we'll share some of that, some data that speaks to that in a few moments. Education. We know that with respect to education attainment, higher educational attainment is associated with improved health outcomes. But we also know that education, particularly in the public school setting, is grounded and funded based on property taxes that again are driven largely by home values. And so it stands to reason, and the data suggests that those areas where there's lower property values, their schools receive less funding relative to more affluent or areas with higher property values. And you see some of the others listed there, including employment, earnings, benefits, credit, etc. But I would present to you that with all the focus that we've been hearing about health equity in the last few years, particularly around COVID, I want to remind the audience that health inequity is not new. So in his classic 1899 book, The Philadelphia Negro, noted American scholar, sociologist, and civil rights activist W.E.B. Du Bois provided a detailed characterization of what at the time was known as the Negro problem in America. His insightful analysis indicated that higher level of poor health for Blacks was one important indicator of racial inequality in the United States. Now, when we look in context in the late 19th and early 20th century, the predominant medical paradigm attributed many of the observed differences in health to innate biological differences between racial groups. But Dr. Du Bois saw that racial differences in health were more reflective in terms of social and what he called social advancements. He indicated that the vastly different conditions under which Blacks and whites lived contributed to the observed health outcomes. And he argued that racial differences with respect to health were multifactorial. And when we consider that, despite them being multifactorial, he considered that social factors were the most prominent. He was truly a scholar ahead of his time. Some of the things that he listed in terms of contributing factors include genetics, but he also included neglect of children and infants, poor dwellings, poor food, and insanitary living conditions as contributors to the observed health disparities that were present in Black patients or Black citizens of Philadelphia versus white citizens of Philadelphia. And so understanding that as the backdrop and recognizing that health disparities is not something that just developed, let's take a few moments to unpack what are some of those factors that contribute to chronic health inequities. And so among those is patient factors, certainly. So patient adherence to treatment. We talk about self-care behaviors and lifestyle behaviors. Language and literacy. Does the patient have high health literacy or low health literacy? And their own sensitivity to their own race, but also potentially experiences with the healthcare community. Some provider factors can also contribute to health inequities, including provider bias, patient labeling, lack of time from providers during visits, language barriers, or racism. With respect to healthcare system factors, things like workforce issues. And when we talk about workforce issues, we're talking about the diversity of caregivers, a lack of interpreters or interpretive services for those that speak or English is a second language, or they may not even speak English at all. Access to care. When we talk about access to care, we're talking about insurance, whether that be public or private insurance. Also, time constraints on relationship building, going back to the time constraints in terms of visits with patients. And then differences in quality, and we'll spend a few moments talking about that when we talk about some of the drivers of disparities in critically ill patients in a few slides. And then lastly, when we talk about chronic health inequities, social and structural factors, as well as systemic racism, can contribute to those chronic health inequities. Now, I tried something new here, and we said we're going to put in a few poll questions, and so let me see if I can navigate through this. And so I think it should be open now. So which of these levels in care do racial health disparities exist in critical care? Do they occur in disease incidence, clinical presentation, or clinical management? I see some of the poll results coming in. Looks like, and I guess I'll wait for a few moments before I spoil the results, I guess. But give folks maybe another 10 seconds or so, and then we'll move forward. Okay, so I don't know if you guys saw the results, but I'll read them to you. 22% had indicated disease incidence, 6% indicated clinical presentation, and 72%, so the vast majority of respondents thought that racial disparities exist in clinical management. All right, so keep that in mind as we go through the rest of the presentation and the next section of the presentation, just to see if what you chose aligns with the actual data and statistics. All right, so one of the things that I wanted to highlight with respect to health inequities in critical care is to understand where do disparities exist in critical care. So disease incidents certainly contribute to health inequities, and we'll unpack that a little bit further, but such things as chronic comorbid conditions, socioeconomic status, health behaviors of our patients, but then also access to care, all have an impact on disease incidence once patients get to the intensive care unit. Clinical presentation also has the potential to illustrate different disparities, and we'll spend some time talking about that in a few slides as well, to unpack that a little bit more in critical care. Clinical management also has inequities associated with it in critical care, specifically around healthcare delivery and processes of care, socioeconomic status and access to care, preferences in care. So our patients with their preferences and beliefs and cultural norms that they bring with them and their families bring with them to the intensive care unit can contribute to differences in outcomes. Additionally, provider bias and language barriers and racism can also contribute to disparities in clinical management. And lastly, outcomes. So healthcare delivery and processes of care, as well as socioeconomic status and access to care, all have the ability to impact outcomes. And so looking at its totality, disparities hit multiple spaces in critical care. But I wanted to look at it a different kind of way. So when we talk about disease incidence through presentation, through clinical management, through outcomes, that really spans the continuum of acute critical illness. And so Soto and colleagues had published a beautiful review in critical care medicine that highlighted and spoke to where disparities are present across the continuum of acute care illness. And so with respect to reported health disparities in critical care, when we talk about disease incidences, we know that these things can lead to differences in presentation and management, but there have been well-described literature that shows decreased immunization rates among historically minoritized groups as compared to non-Hispanic white patients. We've seen increased rates of sepsis and acute lung injury. Various studies suggest that among racial and ethnic minority groups. Additionally, disease incidence with respect to HIV, chronic kidney disease, diabetes, mellitus, as well as alcohol abuse, there has been data that shows that there's increased rates of those disease in racial and ethnic minority groups, but also increased risk of VTE and increased risk of out of hospital and in hospital cardiac arrest. Shifting gears towards presentation and the way patients present to the intensive care unit, racial and ethnic minorities, various studies have shown increased infection rates depending on the disease state, but very specifically in the rates of community-acquired pneumonia, as well as for women, UTI infections. Additionally, gram-positive infections have been illustrated to be more common in African American patients, as well as in men who present with sepsis. We know that insurance and socioeconomic status can certainly impact patient presentation, because the deficiencies in not having insurance or having low socioeconomic status are associated with delays in receiving preventative care or routine maintenance, and so leading to patients presenting in later stages of disease. Also, patients can present with increased severity of illness and increased acute organ dysfunction. With respect to clinical management, when we talk about clinical management, decrease or deficiencies in healthcare delivery among racial and ethnic minorities, which oftentimes is a function of institutions that they that service areas that that have a large number of historically minoritized groups. There's also data to suggest that racial and ethnic minorities receive different levels or have lower rates of central venous access. Hopefully nobody's using pulmonary artery catheters anymore, but I kid. But pulmonary artery catheters is dialysis and tracheostomy. Additionally, I talked about it briefly, safety net hospitals. There is And the data would suggest a decreased quality of care and financial constraints at safety net hospitals, which oftentimes serve communities of color. And then in terms of clinical management, we see increases or higher intensity of care at the end of life for racial and ethnic minorities as compared to non-Hispanic white patients. And then outcomes. And so increase in sepsis and ALI, excuse me, acute lung injury mortality. We've seen increases in VTE mortality and cardiac arrest, and increases in mortality in trauma patients among racial and ethnic minorities as compared to non-Hispanic white patients. And so that leads me to kind of my first take-home point. And the poll that we asked was a little bit of a trick question, and my students would have pitchforks at my door if I were to put that on a real exam question. But really and truly, racial disparities are present at various levels of critical care. So it's not just one area, one magic thing that we can focus on. It really is across the continuum of care. And so that's really important to note. So let's shift gears a little bit and talk about health disparities in critical care. We'll use COVID-19 as kind of the initial framework, but then we'll also talk about health disparities in disease states beyond COVID-19. And so first, let's talk about disease incidence. And so we talked about those different buckets of care where disparities exist. And so the first is disease incidence. So there are a number of different things that can address and impact disease incidence. Let's first talk about genetic susceptibility. And so genetic variations can alter host immunological response and certainly modulate the risk for infection and critical illness. The literature tells us and suggests that several variants of genes are involved in inflammatory and innate responses to infection, and they have been shown to show different allelic frequency by race and gender. And that's been shown in patients with acute lung injury and sepsis. And that suggests that race and gender may have variable inherent response differences to infections. In addition, polymorphisms as it relates to things like TNF beta are associated with higher risk of sepsis in men. Additionally, there's been allelic variants in things like myosin light chain kinase, which confers a higher risk of sepsis and acute lung injury in African American patients. However, when we talk about genetic epidemiological studies of critical illness, they oftentimes are limited because of the small sample size that they've had, or the fact that they include a mostly white patient cohort. Small sample size, and then variable methods for adjustment of population admixture, and then difficulty in defining race genetically is hopefully well known to this group. Race itself is not based in biological differences. It really is a social construct to prioritize different groups over others. And so genetic susceptibility, however, doesn't fully explain the differences in prevalence for common acute critical illness diseases. So for example, I talked earlier about VTE risk in African Americans. However, African Americans don't carry the most common mutations associated with higher risk of VTE. Additionally, when we talk about chronic comorbid conditions, it's not, and the data would tell us that there are racial differences in comorbid conditions prior to hospital admission, and that those differences increase the susceptibility of patients to acute critical illness. So for instance, when we talk about patients with diabetes, hypertension, etc., increasing the risk for macrovascular complications, that's an example of what we're talking about there. Additionally, African Americans have higher rates of comorbidities that increase the risk of acute respiratory failure, as well as sepsis and acute renal failure. Non-white patients also have more chronic comorbid conditions that alter immune function. So for example, HIV, chronic renal failure, or diabetes as well. When we talk about socioeconomic status and health behaviors and access to care, there is considerable evidence that among and considering these factors, services and outcomes differ by socioeconomic status, race, and ethnicity. Differences in socioeconomic status and environmental factors such as education, poverty, segregation, all contribute to poor health habits that our patients may have. So for example, if a patient lives in a food desert, they are less likely to eat healthier, nutrient-rich foods. Even worse, in patients who are unfortunate enough to live in an area that is has a high volume or high density of fast food restaurants or convenience stores and lack of access to high quality foods, those patients actually are at greater risk because they are in what is known as a food swamp, which essentially is areas that are high in low quality food. So food deserts is low access to food. Food swamps, excuse me, illustrates those patients that are at risk of unhealthy foods in their neighborhoods. And so those things can add to behaviors in terms of increased uptake of unhealthy foods, and again place them at higher risk for acute critical illness and poor health status prior to hospital admission. So I'm going to share this slide, and it's probably well known to this group. COVID-19, when we look back at some of the initial reports of outcome or incidents of COVID-19, but we saw that among patients with, and this is looking at cases, that as compared to non-Hispanic white patients, racial and ethnic groups had higher rates of COVID-19 acquisition or cases as compared to, again, the white, non-Hispanic patient population. Now that's cases. Let's take a look at COVID-19 associated hospitalizations. You see that same picture is present here and illustrates that as compared to non-Hispanic whites, you see that American Indian, Alaska Natives, Black, African American, Hispanic or Latinx patients all have increased relative rates of COVID-19 associated hospitalization per 100,000 population, and you can see those statistics listed there. However, this data is from looking at the entire pandemic. What about now, given that we've had vaccinations become available, we've had new therapeutic options that are available, and I would present to you that the data has largely persisted. This was a report from the CDC that recently was released, and it illustrated that as compared to the earlier phases of the pandemic, looking at recent hospitalization rates, looking at COVID-19 associated hospitalization in adult patients, we saw that Black non-Hispanic patients had 3.8 times higher risk of COVID-19 associated hospitalization per 100,000 adults as compared to non-Hispanic whites. And so this really illustrates that as we strive and we're all want the pandemic to be over, we need to be mindful of ensuring that we not only overcome vaccine hesitancy, but we also work to improve access to vaccinations as well to really fight this disparity. But let's take a step back for a minute, right? So I talked about COVID-19 and some of the disparities as it relates to disease incidence, and we know vaccinations can, lack of vaccination increases the risk of COVID-19. But let's shift to what are some differences in relates to disease incidence in critical care related disease? And so sepsis itself, there has been literature to suggest that African Americans have a 67% higher age and sex standardized rate of severe sepsis than non-Hispanic white patients. Shifting towards acute lung injury and ARDS, I talked earlier about some of the genes that are present, but quantifying what that looks like, that the presence of variant alleles in myosin light chain kinase were higher prevalence in African American patients and strongly associated with the risk of acute lung injury development as compared to whites. And you see nearly double or a little bit over 2 times the higher odds ratio as compared to non-Hispanic whites. When we look to VTE, using an age-adjusted incidence rate, African Americans have higher rates of VTE as compared to white patients. And then African Americans also hold a 3-fold higher significant race-adjusted incidence of out-of-hospital fatal VTEs as compared to white patients. And so all of this as a backdrop to disease incidence just highlights that factors can influence the presence of disease in that patients present with in the intensive care unit. And so let's try this again with another poll question. And so the question is, which of the following are contributors to racial health disparities in the clinical presentation of critically ill patients? And so let's see. And so the answers there are, or the choices are genetic susceptibility, access to care, healthcare delivery, and differences in preferences for care. So again, in this case, we're talking about clinical presentation of critically ill patients. What are things that drive the clinical differences in clinical presentation of critically ill patients? We'll give folks another 30 seconds or so to get their answer in. All right, so it looks like they've seen slow down, and so all right, so again, with respect to the results, 75% of folks thought that the answer was access to care, and 25% that the answer was related to healthcare delivery. That both of those that they contribute to differences in clinical presentation among critically ill patients. So keep that in mind as we go through the rest of the next section. All right, so those factors that really have been demonstrated to lead to disparities in clinical presentation have largely been defined as those that contribute to access to care and preventative health services, as well as those chronic comorbid conditions. And so we know, for example, the higher rates of invasive pneumococcal disease in African Americans are most likely due to lower rates of pneumococcal vaccinations. Furthermore, we know that patients that have been hospitalized with community-acquired pneumonia, that prior vaccination is associated with increased survival, decreased risk of respiratory failure, decreased length of stay, and ICU admission. So again, when we talk about those preventative health services, things like vaccination matter here. Additionally, lack of insurance contributes to that, but also can contribute to a greater burden of chronic comorbid conditions, as well as delays in seeking medical care and diagnosing conditions that place patients at higher risk for critical illness or higher severity of illness. And so there have been several chronic medical conditions that differ in terms of presentation. One of those is in-hospital cardiac arrest. Compared to white patients, African American patients are sicker at the time of cardiac arrest, oftentimes have higher rates of renal insufficiency and need for renal replacement therapy, diabetes, baseline CNS depression, stroke, pneumonia, sepsis, as well as major trauma. And so when we talk about what are the reasons for those disparities, again, they're largely driven by those social and structural determinants of care. And we'll spend some time at the end of the presentation when we talk about a path forward, thinking about what are some of those factors that influence care. With respect to access to care, I wanted to spend a few access as well as preventative care. I wanted to spend a few moments, again, using COVID-19 as our backdrop to understand what that means in terms of differences in preventative care. So Wynn and colleagues recently published an article in Nature that sought to explore racial, ethnic, geographic, and socioeconomic impact on vaccine hesitancy as well as uptake in the United States and in the UK. It was a cohort study that used the COVID Symptom Study or CSS smartphone app to capture information from the beginning of the pandemic, March of 2020, through the initiation of vaccine rollout, which was February of 21. And they collected multiple variables, and you see those listed there, including vaccine willingness, the reason for hesitancy, race, ethnicity, and age. Additionally, they identified sex at birth, comorbidities. They collected information on the occupation of the patient, and then they also collected community level socioeconomic measurements, specifically looking for educational attainment as well as socioeconomic status for patients, specifically looking at the neighborhoods they lived in. And so this was a very large cohort. It included 1.3 million volunteers. And you see the distribution between US and UK participants, primarily in the UK. The data that I'll present moving forward is focused on the United States, and that'll become apparent why I'm doing that in the next few moments. The cohort was 95% white and 5% non-white. With respect to looking at the adjusted odds ratio for various study measures. First, let's look at vaccine hesitancy. Again, this is looking at US patients. Looking at those, and again, this is a adjusted odds ratio, and anything greater than 1 indicates increased odds, and anything to the left of 1 indicates lower odds ratio for the respective outcome. And you can see that with respect to hesitancy, that was common among all racial ethnic groups as compared to non-Hispanic whites. However, with respect to uptake, the only group that had differences were among Black patients. Now, looking at that by itself, one would look and could consider that there is that's one large cohort. But as you know, there's significant heterogeneity within populations. And very specifically, looking at educational attainment, we saw those patients with higher educational attainment. Actually, there were no differences as compared to non-Hispanic whites with respect to uptake. That difference was largely driven by patients with low educational attainment. Furthermore, when we look at income, again, high income Black patients, there were no differences as compared to non-Hispanic white high income earners. But when you look at compared to looking at Black patients with respect to uptake and looking at income as the a variable, there was a statistically significant difference there and lower odds of vaccine uptake. So what does that mean? So that tells us, and the literature tells us based on this study, that the differences in self-reported vaccine hesitancy and as well as these uptake differences were only reported in the United States. Actually, in the UK, there were no differences in uptake or hesitancy among different populations. Now, in contrast to the UK, which has a centralized vaccine delivery and data collection service, initial US efforts were largely driven by state and local health authorities, and that looked different in different counties and states. When we look at this data, the important thing that I take from this is that when we consider education and socioeconomic status, those things are crucially important to outcomes and illustrate that there is significant heterogeneity within populations. In particular, when we look at Black patients, the differences that we see here, where high income patients and high education patients didn't have any differences with uptake, but low income and low education patients did, that illustrates that some of the differences may be due to hesitancy, but it's more likely due to disparities in access that are driving those differences. Let's shift gears and bring it maybe a little bit closer to home. Antonito and colleagues wanted to explore racial and ethnic and geographical and socioeconomic disparities in the distribution of vaccines in the early phase of vaccine distribution across the state of Florida. They did a geospatial analysis of zip codes and demographic factors from the 2019 American Community Survey data, and they looked at 974 Florida zip codes that and zip codes that did not have any patients or any citizens were excluded. The variables they looked at include median age, racial ethnic makeup, at or below poverty line, low education status, and socioeconomic, or a single patient household. If you and just to give you a little bit of backdrop, the vaccine rollout in the state of Florida was largely placed in the hands of Publix initially, public supermarkets, and so the reason that was done was because Publixes were deemed to be ubiquitous or high access areas for folks. However, the data would suggest different, that actually 47.5, almost nearly half of all zip codes didn't have a Publix. Additionally, 34% of zip codes had a Publix, but they didn't have the vaccine available. And 18%, only 18% of Florida zip codes had a Publix and had the vaccine available. When we read the research a little bit further, they did hotspot analysis to identify what were the characteristics of areas that had a high density of Publix plus vaccine, and those areas tended to be moderately populated, older, more white, higher educated, as compared to cold spots. And so the regions that were considered hotspots meaning they had higher density of these vaccine plus Publix areas, were Southwest Florida, east and southeast regions of the state, as well as the northwest panhandle region. Additionally, when you look at some of the factors here, you can see there was a statistically significant difference in age, and this is some of the data that we present. I just highlighted that those areas tended to be less. They tended to be less non-white. They tended to be more educated and lower rates of poverty and higher median household income as compared to areas that didn't have a Publix or those that had a Publix but weren't offering the vaccine. And so again, there were significant differences between Publix vaccination classifications and socioeconomic status. And then those cold spots where there's low density of Publix stores with the vaccines were found to be either very rural areas or very highly population dense areas, higher proportion of Hispanic residents, higher proportion of single parent households, And it's interesting because some characteristics that were shared by rural and inner city settings in Florida were similar. And so health disparities with respect to location are actually similar in rural and urban areas. Just to put a map on it for those of you that haven't been to the state of Florida or are less familiar with the state of Florida, the green bars here represent, or the green areas represent cold spots. The red spots represent hot spots where there was higher density of vaccination spots. And you can see how that may have had an impact on vaccination rates. I'll add that the areas, the cold spots, Tallahassee, Tampa, St. Pete, Orlando, and Miami, represent nearly 50% of the population of the state of Florida. Additionally, those vaccination rate differences persisted even 6 months after rollout. And so largely, I'll say that policy decisions, the decision to only use Publixes and only a small minority of Publix stores added to potentially exacerbating health disparities, particularly as providers. We know that vaccine and vaccination for COVID certainly has implications in terms of reducing severity of illness, and I think may contribute to some of the things that we saw with respect to disease severity associated with Omicron. But I'll ask you, think about what are the implications for critical care in this setting, right? And I think policy here actually negatively and exacerbated health disparities as it relates to COVID-19. I wanted to briefly highlight when we talk about access to critical care, there are disparities as it relates to access to critical care services. So in a study performed by Cantor and colleagues, they sought to examine disparities in community ICU beds or ICU beds that are in communities based on the median household income. And they examined CMS data and compared that to other demographic data through the American Community Survey. And they found essentially that there were large gaps of access as it relates to income. So in looking at the lowest income patients, 49% of low income communities had no ICU beds. And so these different shades of green represent 0 beds, 0 to 4 beds, 4 to 7, and greater than 7 beds. And so in low income neighborhoods, 49% of those neighborhoods have no ICU beds in the community, as compared to only 3% in high income communities. And so income disparities as it relates to the availability of community ICU beds were actually more common in acute areas, or more common in rural areas than in urban areas. And I'll say that the major take-home point here is that policies that facilitate coordination amongst hospitals are needed to address shortages in ICU hospital bed supply in low-income communities. And so patients have to go farther. If you're in a low-income neighborhood, you have to go farther to receive care, which has negative consequences as well. So let's again, and can impact clinical presentation. So just briefly wanted to highlight specific critical care related diseases and differences in clinical presentation based on race and ethnicity, as well as gender in the case of sepsis. So males and African Americans have been demonstrated to be more likely to present with gram-positive infections. And this data is derived from a systematic review and meta-analysis that was recently published in Critical Care Medicine. Non-whites had more comorbid conditions that affect the immune system, and we talked about some of those before, and that can impact clinical presentation of patients. African Americans have higher rates of hospitalization with sepsis as compared to whites. And then African Americans also had a higher likelihood of HIV infection as compared to white patients. Furthermore, when we talk about African American patients, they have a higher risk of acute organ dysfunction and infection-related rates as compared to non-Hispanic whites, and you see the difference there. In terms of acute lung injury and ARDS, African Americans and Hispanics oftentimes, and the data would suggest, have higher mean Apache 3 scores as compared to non-Hispanic white patients. In terms of cardiac arrest, African Americans have lower rates of presenting in ventricular fibrillation as the initial cardiac rhythm, and African Americans were less likely to receive defibrillation and CPR for out-of-hospital cardiac arrest, and more likely to receive medications from EMS personnel. With respect to just global critical illness, non-Hispanic and African American patients have the most physiological derangements at ICU admission as compared using Apache 4 as compared to other racial groups. And so hopefully I've made the case that clinical presentation can be varied based on race and ethnicity, but those are largely driven again by some of those social or structural factors. Now let's shift gears a little bit and talk about health disparities with respect to clinical management. And so when we talk about healthcare delivery, in this case, we're really talking about the type of delivery, that's type and quality of care that's delivered. And so one of the things that can drive disparities in terms of clinical management is the type of institutions that our patients are attending to. And so we know that hospitals that serve a greater number of African American patients are more likely to be urban, more likely to be nonprofit, and more likely to care for patients on Medicaid. And so these safety net hospitals oftentimes lack or have more financial constraints that limit quality improvement initiatives, and also they may lack the infrastructure for the delivery of high quality of care. This has been described in multiple settings, but in very specific cases, community-acquired pneumonia, where African Americans with community-acquired pneumonia in a study were found to be less likely to receive guideline concordant antibiotics within a 4-hour window as compared to white patients. And when we look at those racial differences, they were due to differences in healthcare delivery across hospitals, across multiple types of hospitals. When we talk about socioeconomic status and access to care, the availability of medical insurance certainly is a determinant of the intensity of care and the type of critical care services that are provided. We also know that race and medical insurance can also affect post-ICU care, as well as long-term acute care utilization. Lastly, when we talk about clinical management here, differences in preferences for care can contribute to some of the observations that we see. African American patients as well as Hispanics prefer more intensive level of care at the end of life and are less likely to discontinue mechanical ventilation, have advanced directives and DNR orders, or pursue palliative care. And so the preferences are largely due to cultural beliefs of patients and their surrogates. And it's been identified that African American patients have oftentimes more optimistic views about critical illness. A study done by Mooney and colleagues suggests that race and ethnicity can contribute to discordance between physician communication with patients and surrogates. And so that discordance can contribute to a misunderstanding of care and cultural beliefs between patient and provider, as well as patient family and provider, and certainly can contribute to differences in management. With respect to management, let's use COVID-19 again as the initial backdrop, and we'll spend some time looking at other disease states in a moment. Wiltz and colleagues recently published an article that wanted to evaluate for racial and ethnic disparities in the use of medications to treat COVID-19. And they looked at 41 hospitals, and they were included from March of 2020 through August of 21. And they wanted to explore whether there were treatment disparities as calculated by the differences in percent of eligible patients and they defined eligible patients as having a positive COVID test. And they wanted to look at the difference between the percentage of eligible patients that were treated and look at that based on racial and ethnic minority. They looked at three major drugs, monoclonal antibodies, dexamethasone, and remdesivir. 800,000 patients were included in this study. 61% white, 18% Hispanic, 15% Black. With respect to disease states that patients had that may put them at higher risk for poor outcomes, those include, you see nearly a quarter, or a little bit over a quarter had hypertension. You see diabetes, as well as chronic pulmonary disease, and roughly 9% had arrhythmia and anemia. With respect to actually the medications that were used, not surprising that monoclonal antibodies accounted for a small percentage or a small minority of patients who received monoclonal antibodies. And you see the rates for dexamethasone and remdesivir. So 5% of patients received dexamethasone and 4.4% received remdesivir. When you look at comparing, though, the relative disparity as compared to non-Hispanic white patients, you see largely that the disparities, and in this case, the lower or bars that go down on the y-axis is the percent of relative difference as compared to white patients. You see that monoclonal antibody use was largely decreased as comparing all racial and ethnic minority groups as compared to white patients. But monoclonal antibodies are largely given in an outpatient setting. Let's shift to drugs that are more given on the inpatient side. So dexamethasone and remdesivir. Largely, you can see there weren't a large portion of disparities that were present in the utilization of those drugs. And so when we look at reasons for that, possible reasons, we know monoclonal antibodies need to be administered by a healthcare provider. And so access to care can be an issue. Lack of insurance can be an issue here as well. Differences in treatment with inpatient medications like dexamethasone and remdesivir were less apparent, but that can be attributed to once you get to the hospital, you have relative increased access to medications once you get to the hospital. So let's shift gears a little bit. Again, we're talking about clinical management. I wanted to spend a moment here looking at a different disease state. Again, looking at something pulmonary, but let's take a look at Ball and colleagues wanted to look at race-specific approaches for estimating lung function, and wanted to understand whether the use of race-specific approaches to estimate lung function, whether that itself contributes to racial inequities. And so let's look at that further. This was actually a study that was done as a cohort of a previously reported study, the Spiromic study, and it was a multi-center cohort of people who have smoked or people who are at high risk for COPD. And they, again, wanted to understand and utilize the race-specific approach as utilized by the Hankinson's non-Hispanic white equation to estimate lung function. And they wanted to compare that to a more general formula that did not include race. And they actually compared those formulas to actually observe measurements of lung function. Long story short, about 2,600 patients were included in the study. And you'll see that 33% were non-Hispanic white, or excuse me, 80% were non-Hispanic white and 20% were Black. With respect to smoking status, 33% of non-Hispanic whites were smokers, as compared to 64% of Black patients who reported as smokers. Using these equations, again, these race-specific equations, and the equation gives, with respect to race, in this case, it actually underperformed. It identified that African Americans were calculated to have better lung function as compared to non-Hispanic whites. So and you can see that listed there as respect to a predicted FEV1. However, when we use race neutral or where race was not considered, the Global Lung Initiative formula which omits race from its calculations, African Americans were calculated to have worse lung function. And so you can see that listed there. The major take-home point from this is that using race-specific formulas can yield results that lead to delayed care. In this case, African Americans were identified to have better lung function, which as compared to non-Hispanic whites, which potentially could lead to them being referred to care less often or later as compared to non-Hispanic whites. And you see that when we did it without race, that actually African Americans had worse lung function. And so this really calls into question whether race should be used in the setting of calculating lung function. And potentially they add to disparities. When we look at disparities in clinical management for other critical care disease states, in sepsis patients, non-white patients are less likely to be discharged to another medical facility. African American patients with severe sepsis are also less likely to receive ICU care than Hispanic or white patients. In the setting of community-acquired pneumonia, and I talked about it briefly, African American and whites, when we look at just the receipt of guideline concordant care, there's actually no difference there. African American and white patients receive guideline concordant care at the same rates. However, when you look at the rapidity or how fast that care is provided, African Americans are less likely to receive antibiotics within 4 hours as compared to whites. We talk about cardiac arrest. Delayed defibrillation is higher for African American patients as compared to white patients. And then globally, when we look about any critical illness in terms of clinical management, African American patients have factors which can, and those include faith and pre-critical illness, quality of life, that can influence the perceptions in patients and surrogates. And so again, we talked about it, how African American patients and racial ethnic minorities tend to be a little bit more optimistic in terms of their overall care or outlook in terms of critical illness as compared to non-Hispanic whites. And so that can impact clinical management in critically ill patients. Lastly, when we talk about outcomes or talk about factors, let's spend a few moments talking about outcomes. And so largely when we talk about outcomes, we're talking about two different factors. One is mortality. Certainly that's the big thing that we look at in critical illness, but also functional outcomes. And so functional outcomes, we know that compared to whites, African American patients and Hispanic patients tend to have worse outcomes as compared functional outcomes, specifically related to quality of life, emotional and neurobehavioral complications, and they oftentimes have less community integration and are less likely to receive treatment and be employed after traumatic brain injury. And so those are, when we talk about outcomes, we're talking really about mortality as well as functional outcomes. And so while it's understood that genetics have a ability or account for, can account for disease incidence, it also has some impact with respect to outcomes, but it doesn't account for a large percentage or a large proportion of the differences in racial and ethnic minorities. We know that genetic markers, as I talked about earlier, how they can contribute, but they themselves don't contribute a large portion to the observed and don't fully explain the disparities present. With respect to healthcare delivery and processes, racial disparities in survival for in-hospital cardiac arrest oftentimes can be due to differences in care that are provided by institutions with a high minority population. And we talked about some of the reasons why there. Additionally, it may impact the quality of care that's received pre-hospital in terms of cardiac arrest. We noted that there's differences listed there, and so those differences in terms of out of hospital, or excuse me, pre-hospital care can lead to worsened outcomes in the long run. Additionally, when we talk about socioeconomic status and access to care, again, race and availability of medical insurance are the largest predictor of mortality in critically ill patients as well as trauma patients. In a study that was done by O'Brien and colleagues, the lack of health insurance was associated with sepsis-associated mortality, even after we stratified and controlled for characteristics of the hospital. And the sepsis-related mortality wasn't as explained by other social demographic factors as well. So again, using COVID-19 as our backdrop, again, this is looking at outcome of COVID-19 related death. You see that across different age groups. And so what you're looking at here is age greater than 25 as a whole, and then that broken out into age 26 through 64, and then age greater than 65. We see that in really all of the age groups, but it is particularly noteworthy in patients that are age greater than 65 that the green bars here represent, the dark bars represent men, and then the light bars represent women, that among the racial and ethnic groups, the age-adjusted COVID-19 deaths per 100,000 patients or 100,000 population, all of these among racial ethnic groups were higher than non-Hispanic white patients. And so illustrating that really across the lifespan as it relates to COVID-19, you saw some of those differences, much more pronounced, however, in age 65 or older. With respect to critical care disparities and outcomes, let's talk about, again, patients with sepsis initially. Patients with sepsis have African American patients with sepsis had higher rates of population-based mortality, but after we adjust that data based on age and case fatality rates, were similar for whites and African American patients. So actually, when you look at outcomes, particularly in the setting of sepsis, those it's a mixed bag with respect to outcomes. Some studies show worsened outcomes for African Americans. Others don't show that, or actually even show white patients having worse outcomes. It remains unclear why that's the case, but that's been something that's been observed in some of the literature. With respect to ALI and ARDS, there's been reported higher risk of death in Hispanic patients, nearly 2 times the adjusted odds ratio as compared to non-Hispanic whites. Hispanics have lower ventilator-free days as compared to non-Hispanic whites. And this Duffy antigen receptor polymorphism, which is more often associated with African American patients, is associated with a 17% increase in 60-day mortality and increase in morbidity as tracked by ventilator-free days as well as organ failure-free days. With respect to VTE, hospital mortality is higher for African Americans than white patients, and for men more than women. African Americans and Hispanic patients, they die at a significantly younger age as compared with whites after adjustment for multiple factors, including BMI, sex, genetic variants, as compared to white patients. And so hopefully I've illuminated that critical care racial disparities do exist. They exist with respect to disease incidence. They exist with respect to clinical presentation, management, as well as outcomes. But all is not lost. So what's the path forward? What do we do moving forward to try to better achieve health equity? And so wanted to highlight that the factors that we've been talking about genetics, health behavior, preventative care, environmental factors, community factors, um, as well as hospital-based factors such as delivery and quality of health care, access to care, intensity of care, etc. All of these factors contribute in some way to disparities in acute critical illness. And it should be noted that many of the drivers overlap with each other and cross multiple levels of influence. And so there is no one magic bullet that if you fix this, you'll get rid of disparities. It largely is going to take a multimodal effort to achieve this. Why should we care about promoting health equity? And so, oftentimes when we talk about health disparities and when we talk about patients presenting to the hospital in worse off condition, that's largely driven by outpatient management, right? And as inpatient practitioners, we treat patients as they come in the door, right? But we know that better promoting and working towards health equity is important, at least to improve health outcomes. And hopefully I've shared with you how those pre-hospital outcomes or pre-hospital factors or pre-hospital health can lead to worsened health outcomes in the hospital. If we address health equity, we should see improved health outcomes. Health equity and better promoting health equity can lead to improved quality of care. It can lead to improved patient satisfaction, and then it can lead to reduced healthcare costs. And so, according to one estimate, eliminating health gaps among racial and ethnic groups would cut healthcare costs by $230 billion annually and reduce the indirect cost of excess disease prevalence and mortality by over $1 trillion with a T, $1 trillion over 4 years. And so, as we talk about reducing healthcare costs, health equity has to be at the center of that if we're going to be serious about trying to reduce healthcare costs in the United States. So, what's been recommended for COVID-19? Again, using COVID-19 as the backdrop and saying what are lessons that can be gleaned from that. So, President Biden convened the Presidential COVID-19 Health Equity Task Force. They initially provided 300 recommendations, and they whittled those down to 55. Those recommendations are don't have enough time to go over it tonight, but they provided recommendations in 4 key areas: communications and collaboration, data analytics and research, structural drivers and xenophobia, and then healthcare access and quality. And dare I say, I think many of these areas, these 4 key areas, also can apply to critical care. So, what does better look like in critical care? I pose it that we need to do further research into critical care racial disparities. Very specifically, what are the mechanisms of those disparities? And then what are the impact of interventions designed to reduce disparities? We additionally need to better understand how patients' families are impacted during an ICU stay and how patient and family members' race can affect those experiences. So, for instance, do family experiences at the bedside differ between races? And how does race itself affect communication and decision making in the intensive care unit? Additionally, we need interventions that work and are tailored to address these disparities. So, for example, when we talk about goals of care and having meetings with families and having very serious conversations about goals of care, we should be sensitive to race and culture and be informed about the nuances between different races and cultures so that when we go into those meetings, we can be more cognizant of patients' specific needs and the needs of those families. Additionally, targeted social work interventions that address social barriers to family participation, as well as facilitation of post-ICU care, are things that we need to address if we're going to improve health equity in critical care. Oh, sorry. So one of the things that, as we talk about critical illness and talk about just medicine in general, we spend a great portion of our time focusing in on many of the downstream effects. So we spend a lot of time focusing on management of the disease and trying to prevent mortality, and less time focused on the upstream effects. So things that include addressing institutional inequities, living conditions of our patients. And I think it's incumbent upon us as providers and healthcare professionals to think about how can we individually, but how can our institutions work to address upstream factors. For example, I shared with you the data that showed that low-income areas have less ICU beds as compared to high or more wealthy areas. That's something that no single pharmacist, physician, nurse, respiratory therapist, anybody who's on the team, no single person can do. But those are really policy-related decisions and actions that can we need to strive for those types of solutions. And so the last assessment question is, which of the following would be considered an upstream intervention to reduce racial health disparities in critically ill or in critical care? And so let's launch that. So the answer choices are: increase the number of ICU beds available in low socioeconomic status areas, increase implicit bias training for critical care practitioners, develop programming to reduce high-risk behaviors in teens, and then increase data collection and research to ensure equitable and high-quality care. So I'll give folks maybe another few seconds to answer. All right, and so let's see. All right, so this was a little bit of a surprise. So let me say all of them are needed. I want to make sure that I'm being clear here. All of them are needed, but when we really talk about upstream factors, so 21% of you indicated that answer A was the answer, 14% said B was the answer, C, an additional 14%, and then 50% had indicated that D. And I'll pose it that all of them are needed. And I guess you could make an argument that increased data collection can help inform policy. And so that I could see that. But also I'd say increasing ICU availability in low socioeconomic status areas would be considered an example of an upstream factor similar to what is highlighted here. Right. So in summary, racial health disparities have been identified across multiple levels of care in critically ill patients and for several different disease states. That's important to note. Causes of racial disparities in critical care are multifactorial, but include patient-specific factors, hospital-specific factors, and community-specific factors. And so critical care clinicians, we need to strive to implement processes that allow for the review of institutional data. So many of you recognize the importance of, if you don't look at the data, you're not going to ever improve it. So we need to develop processes that allow for review of institutional data, but then also address upstream components of health. And so with that, I will pause and take any questions. I know that as a Floridian, or as I'm talking to SEC country here, maybe not so many Gator fans, but hopefully we got some in the crowd.
Dr. Allen, thank you so much for such an informative talk. I think you're leaving us with a lot to think about. At this time, we are happy to take any questions, so please feel free to either type in your question, or if you raise your hand, we're able to unmute you if you'd like to participate in the discussion. And can I ask you to please proceed to the next slide so that we can show our
Yes.
audience the CE slide. So at this time, you guys can use the link to apply for CE, which you can obtain if you're a member of the chapter. You can also use the QR code to go to the CE survey. Pharmacy, physician, and dietitian CE will be provided, and at this time, the nursing CE is pending. The approval for that CE is pending. I think I'll start us off with a question. You are a you're an educator, so being that many of us are in preceptor roles, we work with a lot of trainees, starting from students all the way up to residents and fellows. What are some ways that actually on the day-to-day to educate our trainees and get them in the mindset of thinking of these things as part of your medical plan and assessment?
Yeah, no, that's a good question. Actually, it's funny. We had a discussion today with so I'm precepting, and so much like many of you, I also serve as a preceptor for trainees. And so we were talking about patient cases and whether we should include race and ethnicity in patient cases to facilitate discussion about some of these determinants of health and factors that influence it. And so largely in the educational space, we're talking about fictional, theoretical, versus in the experiential setting, we're talking about real patients in your face. And so I think from an experiential standpoint, I think it's as a preceptor, being aware of our own potential biases and how that influences how we think about patients and perceptions. Had a student, the student presented today and really highlighted how our own perceptions can oftentimes get in the way of care that we have or we want to provide for patients. And so being reflective on our own experiences, but then also normalizing that conversation with our trainees. I think sometimes folks are a little bit cautious to have those conversations, but I'll say we all have our own biases. I have them, you have them, we all have our own biases, but normalizing it and in a way giving grace for folks to grow from that. When I'm facilitating conversations about this, I usually focus on when we talk about disease states and X group has more of a disease than others. That's largely not biological. That is largely driven and is a proxy for structural problems, right? And so and structural factors which influence that outcome. And so that's one of the first things I try to contribute to my students. The other thing I want to highlight as well with respects to starting the conversation with students is just being in a space to recognize and understand that my views and the way I learned it aren't the ways that other people have, and being humble enough to recognize that. And I think that goes a long way as a preceptor to model that behavior for your trainees as well. So.
Thank you for that.
My pleasure.
I see a couple of hands up, and I think this may be from now, so I'll go ahead and unmute Nicole. Nicole, you're able to speak if you'd like. You're unmuted. I'm sorry, I can't tell if these hands were up since earlier or not.
No worries.
Okay. I also see Mary's hand up. I feel free to use the questions area that way, because I don't want to unmute audience if
I promise I don't bite. despite my gator picture. I promise I don't bite.
There is a comment that says, "Sorry, you're in Dog County. Go Dogs."
I knew I was going to get somebody that said that. Congratulations. They had a great year. It's been a good year for Georgia in general. World Series too. So
Oh yes. All right. Well, I know we have your contact information, Dr. Allen, and I look forward to our chapter being able to hold more conversations on this topic as we all familiarize ourselves with it. And as you're saying, become more comfortable to even feel comfortable to tackle the topic and have honest and transparent conversations about it. We really appreciate your time and all the work that you put into putting this extremely data-driven presentation for us, and highlighting some very, very interesting facts, and really undermining everything that you said with data to show us what all the stuff that we kind of hear about but don't really have a clear understanding of. So we thank you again on behalf of the entire chapter. We thank all our audience who's joined, and the presentation will be available, will be posted, the recording will be posted on our YouTube channel. We thank you all very much, and we look forward to seeing you in April during our bite-sized lecture, and we also look forward to seeing you in June during our second quarterly meeting. Thank you all, and have a great evening.
have a good night. Thank you so much.